Amazing. Well, good morning, everybody. Welcome to BC Women's Research Rounds. Thank you for joining us on this dark and cloudy, and I think rainy day. So very, very pleased that you took the time to join us. I'd just like to start by saying that the Women's Health Research Institute acknowledges that we are uninvited guests on the unceded ancestral territories of the Musqueam, Squamish, and Tsleil-Waututh nations, and is a provincial research institute committed to improving the health outcomes of women, including those across the 2SL GBTQI A+ spectrum. We recognize our responsibility in the collective efforts towards establishing culturally safe healthcare systems and services that address health inequities among Indigenous people, especially Indigenous women, girls, and Two-Spirit peoples. And we encourage all people involved in research to read both the Truth and Reconciliation Commission of Canada's calls to action and the In Plain Sight report, and reflect on the ways that we can incorporate the recommendations into our work. And as we gather in spaces together, we encourage you to reflect on your own positionality on these lands and your personal commitments to reconciliation. So with that, I'm very pleased to be able to introduce our round speakers for today. Dr. Melanie Murray is a clinical associate professor in the Department of Medicine at UBC. She's also an infectious disease specialist in HIV care at BC Women's Oak Tree Clinic, a staff physician, ID physician at St. Paul's Hospital in Vancouver, and she is a member of the Edwin S.H. Leong Center for Healthy Aging and has been a member of the WHRI for the past 12 years. She earned a bachelor's in science as well as a medical degree and a PhD at the University of Manitoba in medical microbiology. She completed an infectious disease fellowship and internal medicine residency at the University of British Columbia. And her research interests include HIV in women, the role of hormones in HIV and aging, HIV co-infection, and strategies for the engagement of marginalized populations. And she is the principal investigator of the BC Karma Chiwos collaboration, or BC3 study. Dr. Murray is also co-chair of the Quad leadership team of the National Women-Centered HIV Care Hub and the provincial lead for the CHR Canadian HIV Network. And we also have Dr. Hélène Côté, is a professor in the Department of Pathology and Laboratory Medicine. She's a member of the WHRI, an investigator with the Center for Blood Research, and a member of the Edwin S.H. Leong Center for Healthy Aging at UBC. She had her PhD and PDF training in microchemistry at UBC and the University of Washington. Dr. Côté's research interests are in HIV, chronic / latent viruses, aging, markers of biological aging, women's health, antiviral drug toxicity, HIV pregnancy, cohort studies, and community engaged research. She has led the Karma cohort from 2008 through will be leading it into 2028, and now co-leads the British Columbia Karma Chiwos collaboration study on healthy aging in women living with HIV. So with that, I'd like to pass it over to Hélène and Melanie.
Well, thank you, Catherine. So I will be co-presenting today, as you said, with Melanie and Shelley Tugnazzini, who is a BCC3 Community Research Associate who has been with us since the beginning. So Catherine has already acknowledged, but I will too, that we do live and work on the ancestral unceded traditional territories of the Coast Salish people, including the Musqueam, Tsleil-Waututh, and the Squamish nations. I have no conflict, nor does Shelley, and here on the left are Melanie's conflicts. So the objectives today of this presentation are to learn how community partners can be meaningfully involved in basic and clinical research. And myself, I am trained as a basic researcher, and when I wanted to get involved in community engaged research, it looked like something daunting. So we're hoping that the presentation today will shed some light on how this can be done, not only by social scientists, but also clinical scientists and basic scientists. The second objective is to understand the importance of community engagement at all stages of the research process. This is something easily said and less easily done, and hopefully we'll show you some example of how that can be achieved. And to explore novel methods for knowledge mobilization and exchange. We're all familiar with publishing in peer-reviewed manuscript, but this would entail a lot more than that. I want to make a note on language. As part of this presentation, we will often use the term women to describe people who were assigned female sex at birth and currently identify as women, but we acknowledge that not all people who menstruate or have ovaries identify as women, and that their experiences may not be captured in all of our data. Today, this is not going to be so relevant, but yeah, mentioning it. So briefly, what is the British Columbia Karma-Chiwos collaboration study, BCC3 for short? As Catherine alluded to, I led a study called Karma from 2008 to 2018, not 28. And this was a study looking at biochemical and clinical perspective of children and women and the effect of antiretroviral on aging. This study ended in 2018, and there was another one, concurrent study of women living with HIV in Canada called CHIWOS, so the Canadian HIV Women's Sexual and Reproductive Health Cohort Study that went on almost the same years. And that study was really focused on the social structural aspects of sexual and reproductive health in women. And importantly, it was a community-based study. So in 2019, we decided to team up the strength of both of these studies to create BCC3 and taken a holistic approach that took advantage of both the biochemical and clinical strength of Karma, as well as the negative controls that were in that cohort, and all the community-based and social structural aspects of CHIWOS. So this study has been ongoing since 2020, and we're going to describe a little bit more about it right now. From the get-go, we took a cell-to-society approach to study healthy aging in women living with HIV. So this included the things that I had been doing for a while. So cellular and biological factors, studying the effect of co-infection with chronic viruses, effect on inflammation, on immune aging and immune senescence, telomere length, etc. And then we wanted to link that to clinical factors such as endocrine health and hormone levels, reproductive health, concurrent conditions, and medication. But we do all this paying close attention to social structural factors that we have strong evidence now clearly affect health, and this includes food and housing insecurity, experiences of violence, racism, stigma, substance use, how much social support people have, etc. And in all aspects of our study, we try to consider these three bins of factors or variables. In terms of participant, we include women who are age 16 and above, who self-identify as women, and this includes cis and trans women. At the moment, they need to be able to communicate in English, but we will talk about this a little bit later. And they need to be able to attend an in-person clinic visit. We currently exclude women who are pregnant or breastfeeding, but we invite them to come back after breastfeeding or chest feeding is over. A typical, a BCC3 visit includes two parts. The first part is what we call the clinical visit, which takes place in a clinic with a research assistant. It lasts about 2 hours, and we collect the things that are classically collected during research studies. So anthropometric measures, blood pressure, numerous specimens, including blood, hair sample to measure cortisol, cheek swabs, and then we also have optional self-collected rectal and vaginal swabs. At the same time, we also administer a survey that collects demographic information on vaccination and viruses, on medical history, reproductive health, substance use, etc. Within a month of this visit, a second part takes place, which we call the community visit. And this one takes place with a community research associate that I will refer to as CRA from here on. And this is with a woman living with HIV that has been hired by the study and trained to do research. This visit takes about an hour and a half, depending on the women's lived experience. It can be done both virtually or in person as per the participants' wishes. It has to be done, though, in a Wi-Fi environment, and all data goes directly into the BCC3 REDCap database. And participants receive a $90 honorarium once they've done both parts of the study, part 1 and 2. And this community survey collects all the data represented here. So a lot of data on social determinants of health, on emotional and social well-being, on chronic pain, physical activity, experience of stigma and discrimination, sleep, etc. So far, we have, of course, recruited in Vancouver, but we've also done recruitment drives in an effort to have our study best represent women living with HIV throughout BC. So we have been to Prince George, to Victoria. We are currently recruiting in Surrey, and we have planned recruitment drives for the Okanagan and to return to Prince George. And then at the bottom here, I'll show you all the various community organization and clinics that have been partnering with us during these recruitment drive. And typically a drive would involve having our research coordinator travel with either CRA and or trainees or both, and go for several days on location. And while we're there, we typically do knowledge mobilization events as well. So before one starts, though, to do this type of research, and for research in general, one important thing to consider is that although we have the best intention, research can be harmful, especially research that is done with marginalized communities, such as the community of women living with HIV in BC. And if it is not done with care, it can be extractive, it can be traumatizing, and draining for the community members who basically end up giving and not seeing the benefit of the research, not reading the peer-reviewed journals that this will end up in. So this is an example of a manifesto that was published about how to do ethical research in the downtown East Side, where a lot of our participants are recruited. So our approach to try and avoid that has been to embrace community-based research. And this means that several principles we do our best to follow the principles that I will name here. These principles have been gathered from a variety of sources, and they are a guide on how to do community research in a good way. So first of all, it should be centered around relationships between community and researchers. It should engage all parties in knowledge mobilization. So not just the researchers publishing in their journals, but making sure that the information and the knowledge makes its way back to the community to whom it is relevant. It should prioritize the safety of the community. So nothing that we should do should harm our participants and activate them. It should be done in an anti-oppressive manner and trying best as we can to disrupt power imbalances that are inherent between university people, let's say, and community people. It should involve co-learning. We are all in a journey to learn, and I can attest that I certainly have learned a lot since I started doing this. It should integrate a strength-based approach. A lot of research has been deficit-based, always pointing out what is worse, let's say, in people with HIV or people who have any kind of disease or condition. But we try to take an approach where what makes it better for the people we are studying? What are the positive aspects? It should be a collaboration across the research processes, and that means not just during the study, it means before the study, it means after the study, and we will talk a little bit more about that in a moment. It should incorporate the social determinants of health because the evidence is overwhelming that it plays a large role in people's health. And so if not taken into consideration, you're not getting a full picture. And then it should be cyclical and iterative. Just because you started doing things a certain way doesn't mean that it's a done deal. You have to revisit, readjust, and just make sure that you're constantly responding to what you've learned and what others have thought. Am I at the point of passing it on to my colleague, Melanie?
Hélène. So now that we've kind of gone over what the tenets of community-based research are, I'll bring us to kind of back to center on what BCC3 has been. And so when we were setting up the BCC3 cohort, we said, okay, so who are the players? Who are the individuals? Who are the organizations that will be involved in the research, and what are their priorities? And one of the things to remember when you're doing research with community is that you have to kind of consider all of the players and see how you can take those sometimes conflicting needs and responsibilities of the different players and make them into a research study that's good for everyone. So the first thing is we have our community members, so people with lived experience of whatever it is that you aim to study, okay? So community members have expertise in their own lived experience, and they're most in touch with their community's needs. So they'll be able to identify issues that you as the researcher sitting in your little ivory tower may not see, okay? They also have their own priorities based on their specific health needs, the specific context they come from. And so when you're working with community members, it's important to consider having community members coming from a variety of backgrounds so that they can really, you can see all different angles towards what you're studying. The next important player in community-based research are community-based organizations. So this may not exist for all science out there, but it exists for many, many things that we study. Okay, so these are organizations that have expertise in program planning and implementation. They have their finger on the pulse of what the community needs because the community talks to them. Okay, they do have a mandate to provide services to community members, and so that will be above, you know, meeting somebody else's research needs. So if you're going to work with community-based organizations, you really want to have a conversation about how you can be helpful to one another, how you can answer the needs that community have put forward to them, and how, you know, you can work together. And then you have academic researchers who have the expertise in the research processes and theoretical frameworks that are to do with the study that they do. But as researchers, we have to, you know, we have to publish or perish, right? We must publish manuscripts. We present at conferences. We have to get the next grant funded, and we have to adhere to ethics requirements. And sometimes the questions that are put forward, oh, sorry, I wasn't done. The questions that are put forward might not be something that you can answer. And so there has to be a dialogue back and forth about, this is a really important question, but I can't answer it. We don't have the science yet or to answer it, or this has already been answered, and here is the answer to that. Maybe it was in a publication, but it's not been shared with the community, right? And then come to something mutually that works, okay? So the rationale for community-based research, if we haven't kind of hit it home well enough yet, is that it creates better research because we're getting to hear what people living with a certain, you know, condition, what they need, what their priorities are, right? And it results in outputs that are more actionable and relevant than if you're just coming up with the ideas in your laboratory. Okay, it improves the quality of the research because our community organizations and community community members may be able to point out things that you might not think of as the clinician or the scientist, okay? So it includes those things, and it's really informed by the lived experience of the individual. Next slide, please.
I know.
Sorry.
It's okay.
The other thing about community-based research is you end up with a team that has a much wider range of expertise than if you're working individually on your own. So one of the things I'm really proud of with our team here at BCC3 is that we have basic science researchers, clinicians, social science researchers, community members. We have elders working with us on the study. We have numerous community organizations. And we have people coming from all different angles. And so the aspects that they bring and what they're able to put in to our conversations, I think really enriches the research that we have. Okay. The other thing about including community in research is it really improves the community's capacity to engage in research. So by listening to community, hiring community, involving community, making them a central part of the research, it really improves their capacity and their learning and their ability to go on and either start their own studies in some instances or to participate in increasingly more meaningful ways with research going forward. Okay, it builds researcher capacity to engage with community. Okay, so as we practice this, we get better at it. When I first started doing community-based research with the WellTel study in, 2017, 2016, something like that, I basically sat down with an elder and who was introduced to me from someone else. And I'm like, how do I start? What do I do? I knew nothing, right? But as I practice, I do better. I'm always still bumbling, but I'm learning and I'm trying to do better as I go. And so it really, as a researcher, it makes me much more in tune with what's needed. And it brings together those diverse perspectives and skills that really improves your research outputs. Another thing that's really important about community-based research is that community often has a mistrust of the establishment, a mistrust of care practitioners, a mistrust of research. It's common enough, right? And there's a lot of historical traumas, as we all know, especially with Indigenous peoples in our country, but all sorts of other marginalized groups. And by working with community, giving community some control over the research that impacts their lives and health, right? Control over the questions, control over how the outputs are put out. It really prioritizes the community, prioritizes the things that are important to them, and helps to build trust between the community and the researchers and the research institutions. And so what have we done in BCC3? So we started by determining research questions. We actually started by going out and talking to women who were living with HIV at PWN, which was the
Positive Women Network.
Positive Women's Network, which is unfortunately no longer around, but they used to have retreats and we would talk to women there. And then Hélène went out and talked to a bunch of women living with HIV who were involved in the CHIWO study, who was going on at the same time as Karma. And we started to get some questions from there. And we hired some women living with HIV when we were funded. And they were integral to helping us with our survey design when we started this BCC3 study. So they were there, we hired right at the beginning, and they were there from the beginning, helping us. And when it came time to design our survey and include questions, there were questions that were like, yeah, this is not important to us. Like, I don't know why you want to know this. So let's chuck that out. Or this is actually really important. So one of the things, for instance, that came up was pain. Pain was really important. And so we included questionnaires on pain as part of our research. Okay. Women living with HIV have been included in data collection. They help us collect our data for the study. And so it's done in a better way. And I think for our participants, it's nice to have a community research associate administer some of those more sensitive surveys. And then as we've gone on, our CRAs have been involved in data analysis. So there's been some teaching around data analysis, and our CRAs are involved in the abstracts that we write. They're starting to write their own abstract for a conference, which is I'm so impressed. and it's so awesome. So they're starting to get involved in the data analysis. And then they've been an integral part of knowledge mobilization as we take what we learn back to the community, as we take it to journals, as we take it to conferences. And here today, Shelley is here with us to help us with this talk. Okay, so that's what we've been trying to do. The reason this is a circle is that this is an iterative process. Like I said, when I started back in 2016, I knew nothing. And so as I go around this circle, I get better. I still have lots to learn. I still have lots to do better at, but we get better as we engage community in an iterative way. So the first thing we did, so I talked a little bit about it, was consultation. We met with community members. We asked them what mattered to them. And there was a little bit of back and forth. There's like, well, actually, that question's already been answered. Here, we can show you that. Or actually, that we can't answer that question. It's not something we have the ability to do. And then it was like, well, these ones, yes, we can do something about that. And so in discussion, what are we then came back and we're like, what are the research questions we can ask? Okay. And as we go forward, we're doing better, I think, at involving our community members in the application as co-applicants. Sometimes started with collaborators, but now more and more as co-applicants on our applications, as active members who help read over our grants and help to make them better. And I'm going to turn it over to Shelley, who is one of our CRAs who's joining us here today. And unfortunately, she didn't get her bio in because I am too last minute. So I'm going to get Shelley to introduce herself and tell us a little bit about how we have involved community through the research process.
Yeah, so my name is Shelley. I have been a woman living with HIV for 16 years. I was diagnosed in 2008. And I've also been working actively in the HIV community, starting as a peer navigator back when IDC was IDC, and have gradually made my endeavor for me and for a couple of the other CRAs that were hired. So I'll just start at the beginning when we were hired. So we were hired through Simon Fraser as community research associates. We actually started as peer research associates and then decided to change the name to community research associates because we thought it better explained actually our role within the research team. And it also was a good piece for some of the women that were hired that were less comfortable being out completely with their status. So it allowed for a peer to be removed, which was really important to some of the women. It was a very accessible questionnaire to apply, and it was also promoted through organizations and community-based organizations that at the time, this was 2020, that women had access to, and a lot word of mouth. My reason for applying was word of mouth, but the community of people wanting to get into research was new, I think, really, to this level, to this degree of involvement. This was not just be a community supporter of a grant. This was actually a job, and this was a real job with serious training. So the equity and representation was considered in the hiring. So we have women from different ethnic backgrounds. We have women representing the ACB community, the South Asian community, and Caucasian myself. And we had one, the one area that we still need to find is an Indigenous CRA, which has been a hard thing to find. But that's something that we continue to work on and continue to work for. And certainly, hopefully moving forward, we will find that person that wants that job. We were provided with a laptop and Zoom training right off the start, and 4 of us were hired in the spring of 2020. So how did that look, I guess, in terms of training? The training was extremely extensive, and as you can imagine, it was all done virtually. Actually, for the first year and a bit, we had never met in person. We all only met on Zoom, which was, it was interesting. It was good. It was inspiring, but it was also different than any other job training I'd ever had. Not to mention the the Zoom part in general. So we had extensive training, including Tri-Council policy statement, the ethical conduct for research involving humans, harassment and bullying, confidentiality, COVID safety, cultural sensitivity. We also, that was just off the top. That was our training off the top over the first year and a bit. And then the training continued. And as it's been said, the process is it continues to go in a circle. So as we learn more, as we get stronger at our job, in our roles, we have evolved into bigger responsibilities, whether that's and out of our desire to want to do that. So all four of us said, well, we want to learn about
Froze, Shelley.
So there seems to be some sound issues, Shelley.
You hear?
Maybe try turning off your camera, Shelley. I know that's unfortunate, but maybe try that because you're breaking up.
Can you hear me now?
Yeah.
Perfect.
Okay, sorry guys, that's my internet right now this time of day. Okay, so do I have to go back at all or?
No, it's okay.
No?
Keep going.
Okay, all right. So we also obviously had to be trained on REDCap and how to use the database so that the surveys were directly inputted directly into REDCap. And we also had extensive training on collecting a sense of understanding the role of bias and understanding the role of confidentiality and making sure that there was, the coordinator would link us with appropriate participants so that there was a good rapport that evolved again over time. And then we had, ongoing, as I said, interview best practices, protocols that were required, safety and self-care. And it has been, continuing to get stronger over the last 4 years. Next slide. So what do we do? Actually, we were, as Melanie mentioned, we were very involved from the get-go, from the beginning of developing and the survey questions and the pilot study. All of that we were part of. We do the community part of the survey. So one of us will be assigned after they've completed the clinical part of the survey. Within 30 days, we try and do the community follow-up. That's not always possible, but we do our best to do that. We support participant recruitment by attending recruitment drives, by helping with poster drives, by going to community events. Again, word of mouth is always a key factor in community-based. If the community knows that it's good research, or if we can share how strongly we feel about it, it helps build that trust and those relationships in the beginning. We have monthly team meetings, and then we have biweekly BCC3 meetings. We also advise on study methods and materials, support data analysis, support facilitation of the community advisory board annually. We present at research conferences, and as mentioned, have been co-authors on many abstracts and manuscripts. So compensation, interviews, as the participants were paid $90, we were paid $90 to complete the interview, but that also included the time to book it, the follow-up, it's not just the interview, there's also the reaching out to connect and book the appointments, and that can go on. Like, it's not like you pick up the phone and oh yes, I'm ready, I'll be there Tuesday at 3. It's not that straightforward. So there's a lot of back and forth trying to book someone, and there can be technological issues. There can be, I guess the main thing is we've learned and know that to meet women where they're at is really key. And so if women want to meet in the downtown east side, we've made arrangements with certain community organizations where, for example, I've gone into Kalele to do a survey, or I've gone into different organizations with privacy to be able to do that for them, or we do it over Zoom, or we do it over the phone. whatever's best for the participant, we try to accommodate their schedule, their needs, and their choices. So additionally, for all the other stuff that we do, we were paid, the training was paid, all the meetings are paid, any other work that we do is paid. And originally it was $25 an hour, and now we've recently had an increase to $27 with other community research associates across the country. So the biggest and probably one of my favorite parts of the entire project has been knowledge mobilization. We started originally in 2021 with more arts-based knowledge mobilization, and that was led by Dr. Shada Swan and multiple collaborators. It was supported by the UBC Public Scholars Initiative and the UBC CUES Fund. And we did the knowledge mobilization during, which in addition to recruitment drives. So when we went to Victoria, we were doing the recruitment drive, and we also did a knowledge mobilization event. So it was taking advantage of the opportunity wherever we went to share knowledge, and or in the beginning, it wasn't so much about sharing the results, but sharing about the study. So there was a whole period of time where we were actually promoting to get participants to promote the study, but also we were trying to share preliminary findings or just how we got here and who we were, and building, again, relationships and community. We went out and did a sharing and learning workshop with 20 women across the province at Loon Lake, and that was a huge big deal. That rarely happens in research, and that was through women telling us, giving us feedback from the community what they wanted. They wanted an opportunity, particularly during post-COVID or during that time, women were craving that ability to meet one-on-one or person to person. And so that provided a wonderful opportunity. And it also, through word of mouth, spread that information to the north, to the interior. We had women from Nelson, we had women from Prince George, we had women from the island, and it was just an amazing event. And so then that has evolved into what's now the Healthy Aging Talks, which are, we do a live in-person event, which we've been primarily doing with Ribbon Community. And then we do 2 virtual events, presenting the research findings back to the community. And this was something very integral to what women asked for. And when we say feedback is secular, the feedback continues. After every event, we're always evaluating the event and finding out what worked and what didn't. And so to that end, we have evolved now to do 2 virtual events and 1 in person. So we've done several talks, one on healthy heart, liver, and most recently kidney. And we'll be doing further talks on stress, cortisol levels in the new year. So one of the things, this was the, no, you can go. Thanks, Helen. Okay. So these were some of the in-person arts-based events, which were from June 2022 to March 2023. And the themes, they included menopause, chronic pain, stress and cortisol, and resilience. And a lot of this was arts-based activities, and then sort of a layman's presentation of these topics. And these events were, as I said, Vancouver, Prince George, and Victoria, and supported by UBC Community and University Engagement Support Fund and the Public Scholars Initiative, which we have supported again, we have been supported with again this year. 6 to 20 women per event, depending on where we were. And that's, I think, been as we move forward into the next series of talks, that's increased. So the women love these events. As you can see from these pictures, this is us out at Loon Lake. And some of the quotes, the best time ever. Presenters were clear, easy to understand. They were amazing. We need to have this retreat. I know more about cellular aging and chronic pain. This weekend has gifted me with more knowledge, a sense of belonging. My heart cup is full. My life feels enriched from the experience. And it was magical. I mean, in terms of research being magical, it was magical. So women are really interested in their health-related research findings, and that includes both women living with HIV or
Shelley, you're breaking up again. Are you okay? Try again.
Is that
Try
better?
again.
Yeah.
Yeah, but you're gonna have to start at the beginning of this one.
Okay. Sorry about this. So in the Healthy Aging Talks, we do specific, tailored, individualized results. So what happens is that we do the booklet, which we don't have a copy of here on this slide, but we have a booklet and they can request a You Are Here star. So as you can see from the graph, there's women living with HIV in purple dots and negative women in gray dots, and you can get, this was in particular for a 10-year risk of a cardiovascular event, and looking at the horizontal axis being age in years. And so women really, really appreciate the fact that they can get these results, and also highlight as well for controls, a lot of women don't even get the full blood panels that they would have gotten. This was really helpful to them. If they didn't have a primary care provider or they hadn't seen their GP in years, they were given this wealth of information that was really helpful to them as well. So it works for both the controls and women living with HIV. It also comes with tips on how to talk with care providers. It talks about, there's resources available, it's all in lay language, and they are mailed, not particularly at this point in time, but they are mailed or can be digitally sent. And so this has been something that the community wanted and something that we delivered back. And so now we have done the risk scores for liver disease, heart disease, risk of declining kidney function, and in the new year, we'll be working on cortisol. So with that, they're also one of the most amazing things, I don't know, most amazing, but one of the really cool things is that we have created some really dynamic booklets. And this one in particular, if you want to see an excellent resource on menopause, I highly recommend that you click that QR code and it's beautifully illustrated. And Katie actually, which is the national source for HIV and hepatitis C information, has published it, and it is handing it out. And it was an absolute, just an amazing, beautiful resource that's now available nationally because of the work of the BCC3 study. So with that, I'm going to pass it back to Melanie, but I do want to just say, when community-based research is done well, it builds passion, it builds inspiration, and it encourages the community to want to participate. And because historically women have been under-researched in HIV, this is a new era for women living with HIV to see research being done in such a mindful.
Thank you, Shelley. I think we're going to pass it back to Melanie.
Thank you, Shelley. So one of the things that women have told us in our knowledge mobilization events and in speaking to different members of the community and people who've worked, who've done this study, is that they would love to see knowledge mobilization materials in their own language, because quite often they have a hard time if they're a newcomer, they're coming from another country, quite often they have a hard time understanding these knowledge mobilization materials in English, or maybe they don't read English, but they may understand another language, the one that they started with, right, from their home countries. And so, and the other piece of advice that we were given would be to translate our consent forms and our study questionnaires to other languages to make it more accessible. And we certainly know from experience that there are a number of women who attend Oaktree Clinic even that can't participate because they're not fluent enough in English to be able to do so. And so taking that, we worked with ACPNet and we're able to get a little bit of funding to do a translation project. And one of the things, this translation project was $20,000 from the CUES fund to do translation. And the typical way of doing translation is to send it out and get a translating service to do the translation for you. And so we were quoted from Katie, for instance, who does it. Our $20,000, we could do 2 languages to have our documents translated. Okay, so pick your 2 languages. It's actually quite expensive. It's about 15 cents a word. Okay, and so we're like, can we do this in a better way? And so working with community, we've met with community and we asked them, you know, what their thoughts were, what languages they would want, what their thoughts were about this. And they were like, you know, we speak all these languages. Why can't we do it? And so going back iteratively to the community, we had a student hired over the summer as a student project. And she actually went and looked at the different artificial intelligence translating softwares that were available. And she sought out which one was better for different languages. And so some software is better for your Romance languages, some is better for your African languages. So different AIs are better for different ones. And she did all the groundwork for that. And then she made some sample, sample translations of some of our knowledge mobilization flyers, and took them back to the women and asked them which one is actually done the best way. Right? And so kind of in a go back and forth manner, determined which AI was the better translator. Now that there's good data to say that AI is actually not the way to do translation materials because it misses context, is often not culturally sensitive, right? And so the next step was to hire women. And so from the women that we consulted with, we actually hired women living with HIV who speak these other languages from their home countries, right? Who speak these other languages to be our translators. And so we did the AI translation, which does the bulk of the work. And then the women are given over a secure link, they're given the translated material and they go and they correct it for cultural sensitivity, for context, and then they give it back to us. And we've met with ethics here at BC Women's and Children's, and they're now going to accept we're so excited. They're going to accept our SOP for how we do it, where we do AI translation, then we pay women to check over the translations and correct them, and are able to then put forward that. And with that, we've been able to do 8 languages instead of 2 with the same amount of money. Okay, and you can see in the bottom right-hand corner the languages that the women told us that they wanted us to do. And so they're Gujarati, Shona, Hausa, Zulu, Luganda, Swahili, and French. We'd also like to do Spanish, and we're also working on Punjabi. Yeah, so it's really exciting to be able to do that and kind of bring it full circle. So BCC3 so far, so where are we? You know, we've done a lot of knowledge mobilization so far. We haven't quite finished enrolling. We're at 635 out of 700 participants enrolled since December 2020. We've done about 20 community knowledge mobilization events. We've done 3 recruitment drives outside of the Lower Mainland, and I'll point out this was on the advice of our CRAs who said that we need to have better representation of women throughout BC. So this is responding to that. We have 6 papers published, 2 are submitted and actually just undergoing revision for publication, and 15 in the late stage of preparation. So we're kind of really just starting to turn everything out, and our students and CRAs have done or accepted to do 35 presentations at national and international conferences. So we've really done a lot. In the last couple of minutes, before I give time for questions, where does one start if one wants to do community-based research? So what are the things you have to do? And so the advice that I would give to you is to talk to people with lived experience of whatever it is you want to study. Do it early, do it often, keep circling back. Talk to your colleagues, go and find those who are doing community-based research and ask them where to start. Ask them for help and guidance. Ask them for linkages. Talk to the community organizations. Go online and figure out which community organizations are involved in that which you want to study, and go and talk to them, set up meetings, okay? Apply for funding to support community inclusion. So there are lots of little funds, little pots of money that you can use if you have a study that's ongoing that you haven't included a funding line for community-based research in. And those are the UBCQ's fund, the Public Scholars Initiative, Health Research BC. So just to name a few, there's lots of things out there. But and do write community-based research funding into your grants. Okay, make that line though. Don't expect it to be for free. These people need to be able to eat, right? So we have to pay. We have to support people to be able to do this. And the most important thing, I think, is to be humble. right? To be willing to learn, to be flexible in your thoughts. Don't be fixated, it must be this way, but be open to change and to learn as you go. And remember, I think we've said it a couple of times, but remember that communities-based research is a circle, is not a line, and it takes practice. And the more you do it, the better you're going to get at it. And I couldn't get the circle to go around the right way, but it went the other way. I would like to thank our community advisory board members. So these are those organizations who are involved in our community advisory board, and we meet with them to report to them every year and then ad hoc as needed. We started with many fewer than this, and we add organizations as we go along and as we make new connections, and we're continually making new connections. So I'd like to thank them for all that they have done to support us so far in our journey. And I'd like to thank our supporters, so all the funders who've helped us and those who've really supported us to do this work and to do it in a good way. And I'd like to thank all of the women who have gave their time and been willing to participate in the study as participants, and our CRAs for being part of our research family. So thank you. I think we have a few minutes left for questions. I hope that people found this engaging.
Absolutely. What an amazing overview of community-based research and about knowledge mobilization in general. This was so great. So yeah, folks, anybody with questions, you can just go ahead and unmute yourself, or you can pop your questions in the chat and I can read them out. I saw that Lori was really interested in your translation SOP. So we'd love to learn more about that and potentially share that with other folks, because I think it's a really important learning.
It's quite translatable, so we could certainly send you the SOP. The other thing is that the women who do the translations, they sign a form saying what they're, how they know the language and why they're can do the translation, and they sign that, and that is uploaded with your ethics documents. So yeah, we can definitely share that so that you can share it with others.
Awesome. Jerry Lynn, go ahead.
This is great. I'm very proud to be peripherally part of it. I wondered if in the translation you had them do back translation.
Like back translation to English? We did not. We had, so our student did the translation. First of all, she went and found, tried different AIs and asked the women which one was the best. I gave them samples of different different pieces of our, of the questionnaire, of that, like gave them just samples to read and kind of different data, and got feedback on which one did the best job. And then gave them the one that seemed to be the best, gave them the translated document, and then they would read it through. They would have a copy of the English and a copy of the translated, and then they would go through and correct it for, readability, for proper translation, and for positionality. Yeah. So we didn't get them to do it backwards. No.
Emma, go ahead.
Hi. It's great to hear more about your guys' work in community engagement, because we sort of work alongside at No Tree, but to hear about it in this way is so exciting. I am wondering about, Shelley, when you mentioned that you're getting hired for this CRA position and it's like a job, did you have like specific hours that you work every week or amount of time that you commit consistently? Because one thing that I feel is a bit of a challenge on our team is we've engaged with community, but we're sort of meeting ad hoc when there's things to talk about because we don't want to meet just for the sake of meeting. But then I feel like it's sort of hard to get people re-engaged when there's something to talk about. So I wonder about your perspective there.
Absolutely. So because the training was so extensive in the beginning, it required a huge amount of scheduling on behalf of the coordinator to coordinate everybody's schedule. And that always is a challenge, as you know. But yes, we don't have set hours, and we definitely work remotely from home, but we have the ability or not the ability, we have the opportunity to meet bi-weekly. There's representation. One of us is at the team meeting, which is with all the PIs and all the students. And then on a monthly basis, we always meet, and we have a 2-hour CRA meeting, which we then get to talk about how things are going, bring back feedback from the survey. So when women give us feedback at the end of the survey, we directly bring that right away. That's not something that we're waiting to the end to do. We bring each survey. If some woman says why this question is inappropriate, or this question doesn't resonate, or could you reframe this? We take that back, and there has actually been changes, including the COVID section was evolving. Obviously, at that time, it was, a fairly lengthy part of the study because it was very important to women. And there was a lot of fear in the HIV community about COVID, obviously for obvious reasons. So that was really key. But yes, I'd say we're not on a set schedule. We have to balance life, our work-life balance all the time. And some of us are on disability. Some of us are, so are limited to how much we can earn. But all of that, the PIs have always been very attentive and aware of it. We have always had open communication at any point to contact directly whoever we need to, whether that's the coordinator, the PIs, the students. We have an incredibly open communication stream around the team. I hope that answers, Emma.
Great, thank you.
And I see Kim's question about what guidelines did our team follow regarding people living with HIV compensation in our area. And I guess at the beginning we were guided by CHIWOs and how they had gone about it. It was clear we wanted to pay our CRA above the minimum salary, but it couldn't be so high that other studies would be resentful that because they too may be hiring CRA, and it has to be that it's relatively equitable around in the field. And then after several years, it became obvious that the cost of living had gone up and there was time to increase. And now I think we will have a policy where the increase is yearly based on the cost of living, but also it will be also based a little bit on the expertise of the CRA. So those with more expertise will be making a little bit more.
Any final questions? Well, if not, I would just like to really thank Melanie, Hélène, and Shelley for an amazing presentation. I certainly learned a lot, so this has been wonderful. So thank you, and happy holidays, everybody. We won't have another research rounds until January, so hope you're able to take time and relax and enjoy over the holidays. Yeah, we'll see you in January.
Thank you.